Good morning, respected faculty and my dear colleagues. I am Dr. Ashik Mustafa, Phase B resident in the Department of Prosthodontics at Bangladesh Medical University. Today, I will be presenting on a fundamental topic that forms the bedrock of complete denture prosthodontics: evolution of maxillomandibular jaw relations and articulation from conventional records to digital precision. To set the stage, let us review what a jaw relation record actually is. As defined, it is a record of the positional relationship of the mandible to the maxilla, used primarily for arranging artificial teeth and fabricating complete dentures. Why is this so critical? In an edentulous patient, all natural teeth are lost. With their loss, we lose occlusal guidance, our vertical dimension reference, centric occlusion, and tooth contact points. Therefore, before we can design or fabricate dentures, re-establishing this jaw relationship is the single most important determinant that remains. To cover this topic comprehensively, today's presentation is structured into 5 distinct phases. Phase 1, Foundations and Evolution. Phase 2, Conventional Jaw Relations. Phase 3, Mechanical Articulation. Phase 4, Digital Records and Virtual Articulation. Phase 5, Evidence, Clinical Integration, and Future Directions. Moving into Phase 1, why do accurate records matter so much? They directly govern 3 pillars of clinical success. 1. Mechanical stability. Establishing a reliable foundation ensures denture stability and a balanced occlusion. 2. Patient function. It restores optimal chewing efficiency, patient comfort, and natural phonetics. 3. Clinical outcomes. It provides proper facial lip support for aesthetics while dramatically minimizing tedious post-insertion adjustments. Let us look back at how articulation evolved. In 1805, Gariot introduced the first recorded mechanical hinge device using plaster blocks. In 1858, W.G.A. Bonwill, known as the father of articulation, introduced his theory where occlusal determinants fall within a 4-inch equilateral triangle. In 1866, F.H. Bonwill described condylar translation and introduced the Bonwill angle. The paradigm shift. In the early 19th century, dentures were treated merely as static closure devices. Bonwill revolutionized this by applying geometry, proving that the TMJ distance directly influences tooth contact paths. However, early systems assumed the condyle moved purely in a straight line, overlooking individual anatomical variation. The evolution continued with critical breakthroughs. In 1899, the snow facebow was introduced, allowing us to record the 3D spatial position of the maxilla relative to the hinge axis. In 1901, Christensen observed posterior disc separation during protrusion, what we know as Christensen's phenomenon, which enabled us to program condylar guidance. Mid-20th century pioneers like Gariot and Hanau introduced adaptable articulators and laws of occlusion, which later paved the way for electronic jaw tracking. Hanau established the gold standard for full-mouth rehabilitation in removable prosthodontics. To program semi-adjustable articulators, we use Hanau's formula, L equals frac H8 plus 12, where L is the lateral condylar inclination, Bennett angle, and H is the horizontal condylar guidance. Furthermore, Hanau's quint highlights the 5 key factors governing balanced occlusion: condylar guidance, incisal guidance, plane of occlusion, compensating curve, and cusp height. From the 2000s onward, we shifted from manual pantographics to electronic and virtual systems. Electronic jaw tracking. Optical sensors and ultrasonic systems like Zebras track dynamic mandibular movements. Virtual articulators, CAD/CAM software, allows real-time collision analysis and dynamic occlusion simulation. Digital records. Combining intraoral scans with virtual facebows, 3D facial scans, and CBCT registrations gives us a complete digital workflow. Now let us focus on Phase 2, Conventional Jaw Relations, which are categorized into orientation, vertical, and horizontal relations. Orientation jaw relation is the relationship when the mandible is kept in its most posterior position and can rotate in the sagittal plane around an imaginary transverse axis passing through or near the condyles. Clinically, it establishes the spatial orientation and angulation of the maxilla relative to the skull base. A tilted maxillary plane distorts the occlusal plane and alters jaw relationships during movement. It is conventionally recorded using a facebow. We classify conventional facebows into 2 types. 1. Arbitrary facebows. These estimate the terminal hinge axis using standard anatomical landmarks, like the external auditory meatus. They are quick, simple, and standard for routine prosthodontics. They include ear bow and facial types. 2. Kinematic face bows. These locate the true terminal hinge axis dynamically by tracing mandibular opening/closing movements. They are essential for complex full mouth reconstructions and cases requiring changes to the vertical dimension of occlusion, VDO. While facebow transfers help transfer maxillary orientation, prevent inclination errors, and allow minor vertical adjustments on the articulator, they do have limitations. Routine complete denture outcomes do not always show superior clinical difference over careful arbitrary mounting, and kinematic facebows are highly complex and time-consuming for daily clinical practice. Next is the vertical jaw relation, defined as the length of the face as determined by the amount of separation of the jaws. Errors here cause severe patient discomfort, straining both the TMJs and muscles of mastication. We evaluate vertical jaw relations in two distinct positions, rest and occlusion. Let's differentiate VDR and VDO. Vertical dimension at rest, VDR, a physiological rest position where maxillofacial muscles exist in tonic equilibrium. It serves as our baseline. Vertical dimension at occlusion, VDO. The facial length when teeth or occlusion rims are in functional contact at an established vertical position. It must be verified using facial appearance, phonetics, comfort, and freeway space. To record VDR, we utilize swallow and relax techniques, phonetics, saying M, facial appearance, Willis gauge measurements, and tactile sense. To establish VDO, we use mechanical methods, pre-extraction records, old dentures, or parallel residual ridges. Physiological methods, Niswanga's formula, where phonetics, Silverman's closest speaking space with S sounds, and deglutition. No single vertical record % accurate, so cross-verification is essential. What happens when VDO is wrong? Increased VDO over opening causes muscle fatigue, acute TMJ pain, mucosal soreness under denture bases, clicking of teeth during speech, and a strained facial appearance. Decreased VDO, overclosure, leads to an aged facial appearance, angular cheilitis, frequent cheek biting, poor chewing efficiency, and chronic joint/muscle headaches. The third category is horizontal jaw relation, defined as any spatial relationship of the mandible relative to the maxilla in the horizontal plane, anteroposterior and mediolateral directions. Centric relation, CR, is the maxillomandibular relationship in which condyles articulate with the thinnest avascular portion of their respective discs in an anterior-superior position against the slopes of articular eminences. It is independent of tooth contact and is a repeatable, reproducible reference position. Eccentric relations include protrusive and lateral movements, which allow us to adjust condylar guidance on articulators for balanced occlusion. Centric relation recording methods include 1. Physiological/interocclusal check records, Wax, Zoe, Aluwax. 2. Functional methods, Needleshouse, Patterson's. 3. Graphic methods, intraoral and extraoral Gothic arch tracing. 4. Patient-guided/static methods. For eccentric relations, protrusive and lateral wax check bites remain standard. Each recording medium has pros and cons. Waxes are quick but subject to uneven cooling. Zinc oxide eugenol and plaster offer uniform resistance but can distort if the patient moves during setting. Gothic arch tracings provide clear visual proof of CR, though they require stable record bases. Failure to record accurate horizontal relations results in denture instability, occlusal interferences, poor mastication, and eventual denture failure. In Phase 3, we look at mechanical articulation. Articulators act as the patient in their absence. They hold casts in a fixed relationship, enabling visualization of occlusion from the lingual aspect which is impossible intraorally, and eliminating clinical interference like saliva or shifting tissues. However, articulators cannot perfectly duplicate complex functional movements, and they blindly reproduce clinical errors made during jaw recording. Articulators are classified based on 1. Adjustability, non-adjustable, hinge, semi-adjustable, archon where condyles are on the lower member and non-archon, and fully adjustable, accepting pantographic tracings. 2. Ability to simulate, Class 1 to Class 4. 3. Occlusal theories, Bonwill's equilateral triangle, Hall's conical theory, and Monson's 8-inch spherical theory. 4. Records used, interocclusal check bites versus graphic/pantographic records. Traditional workflows face key bottlenecks: high operator dependency, multiple appointments, wax distortion, manual mounting errors, and labor-intensive lab procedures. This brings us to a core question: Can digital technology overcome these conventional limitations? The shift to digital dentistry aims to improve accuracy, reproducibility, efficiency, and predictability, while preserving foundational biological principles. Instead of sequential physical impressions, wax rims, face bows, and physical mounting, the digital workflow integrates digital scanning, digital jaw relations, virtual articulators, CAD design, and CAM fabrication. Entering Phase 4, digital prosthodontics utilizes facial scanners for aesthetics and VDO evaluation, digital record bases to replace wax rims, jaw tracking systems for dynamic motion analysis, digital face bows and virtual articulators for digital mounting and occlusal analysis. Digital jaw relation recording uses technology to capture, analyze, and transfer jaw positions into CAD/CAM software. For digital VDO, we utilize facial scanning, AI-assisted facial proportion measurements, digital occlusion rims, and digital smile design. This enhances reproducibility and aesthetic evaluation. For digital horizontal relations, we use digital bite registration material scanned intraorally, jaw motion tracking devices, electronic Gothic arch tracings, and dynamic mandibular analysis. This removes much of the manual error associated with wax records. The digital sequence flows seamlessly. Digital impression, right arrow, digital record base, right arrow, digital jaw relation, right arrow, motion analysis, right arrow, virtual articulator, right arrow, CAD design. A virtual articulator is a software simulation reproducing 3D jaw relationships and movements. Digital STL casts are imported, maxillary position is established via a virtual facebow, and dynamic occlusion is analyzed before manufacturing. Popular software platforms include exocad, 3Shape, Ceramil Artex, and DentalCAD virtual articulators. While virtual articulators offer high reproducibility and eliminate laboratory remounts, they have limitations. High initial hardware/software costs, a learning curve, and the fact that they cannot compensate for an inaccurate initial scan or jaw registration. As the clinical Pearl states, a virtual articulator does not replace prosthodontic principles, it replaces the mechanical articulator with a digital simulation. Comparing both workflows, maxillary orientation transitions from physical face bows to facial scanners. VDO transitions from wax rims to digital record bases and facial analysis. Centric relation transitions from wax check bites to digital bite registrations and jaw tracking. Overall, digital workflows offer reduced chair time, high reproducibility, and streamlined communication. What does recent literature tell us? Digital dentures achieve clinical performance comparable to conventional dentures with higher patient satisfaction. Digital workflows reduce chairside time, though conventional border molding remains important for optimal retention. Milled and 3D printed dentures offer reliable clinical outcomes. While workflow efficiency is superior, evidence for universal clinical superiority is still emerging. To summarize clinical integration: 1. Practical benefits, efficiency and reproducibility are significantly improved. 2. Clinical reality. Long-term clinical performance is comparable, not necessarily superior, to well-executed conventional techniques. 3. Biological foundation. Digital technology is an evolution of tools, not a replacement for fundamental prosthodontic principles. Looking ahead, the future of prosthodontics involves artificial intelligence and machine learning for automated occlusal optimization, 4D virtual articulators integrating real-time jaw movement tracking, digital twins of patient anatomy for cloud-based comprehensive treatment planning. The key takeaway is clear. The future lies in integrating biological principles with digital precision. As take-home messages: 1. Jaw relation success is fundamental to complete denture function. 2. Conventional principles remain our biological foundation. 3. Digital tools streamline efficiency and precision. 4. Virtual articulators complement, never replace, sound clinical judgment. 5. Clinical trial evaluations and occlusal verifications remain essential prior to final delivery. In conclusion, our core clinical goal remains unchanged regardless of the technology used: to accurately record maxillomandibular relationships and deliver stable, functional, and comfortable dentures. I would like to close with a quote by Dr. Carl O. Boucher. "It must be recognized that the person operating the instrument is more important than the instrument. If dentists understand articulators and their deficiencies, they can compensate for their inherent inadequacies." Thank you for your time, and I now welcome any questions.